join me on this video. This video is about the physical examination for laxity of the medial collateral ligament. And by this point, you've already watched video number 1 on patellar instability. And we'll continue on this video with discussion of laxity of the medial collateral ligament. And then on our final video, we'll talk about the physical examination for the assessment of chondromalacia patella. So with regards to laxity of the medial collateral ligament, our physical examination is going to follow the same protocol that we followed for patellar instability. We begin with inspection, move to palpation, and we won't repeat those procedures here on this video because we went over those in depth on the prior video. But I will simply remind you that with inspection, we're looking for any signs of abnormality around the knee. So what would some signs of abnormality be? Any swelling, any ecchymosis or bruising, any skin changes which would indicate damage to the autonomic nerve fibers, any signs of bursitis, any signs of atrophy of the quadricep muscles. All of those would be relevant in a case of laxity of the medial collateral ligament. So we're looking for any signs of abnormality. Then with palpation, we're going to follow up our inspection and palpate for any abnormalities that we found. Now with regards to the medial collateral ligament, we also want to specifically palpate the medial collateral ligament itself. So let's demonstrate that, and let's draw in the medial collateral ligament. Okay. Now, the medial collateral ligament, true to its name, is on the medial aspect of the knee. And the medial collateral ligament has 2 bands. Now, it has a deep band which attaches centrally on the midline of the knee joint, and it attaches on the medial meniscus of the knee joint. Then it sends a band superior, and this is known as the meniscofemoral band because this attaches up on the femur. It then sends a band inferiorly to attach on the tibial plateau, and this is known as the meniscotibial band. So this is the deep band here of the medial collateral ligament. Now on top of the deep band sits a bursa. And the purpose of the bursa is to reduce friction between the deep band below and the superficial band above. So the fact that there's a bursa between the 2 layers indicates that these 2 layers of the medial collateral ligament are separate, are distinct, and have unique functions. So the superficial band of the medial collateral ligament overlays the bursa, which overlays the deep band. Okay? Then we have the superficial band, and the superficial band attaches approximately 3.2 centimeters superior to the medial epicondyle, which is right here. 3.2 centimeters, just a little bit over an inch, and approximately 5 millimeters posterior. So here is the superficial band of the medial collateral ligament. The superficial band then extends inferiorly to attach approximately 5 centimeters, much further distance, onto the tibia. And it attaches on the tibia right underneath the tendons of the pes anserinus. And you remember that the pes anserinus includes the tendons of the sartorius, of the gracilis, and the semitendinosus. And if you remember back to Anatomy 101, we had the mnemonic to remember the pes anserinus as SGT-FOT. And SGT referred to the tendons of the pes anserinus was the sartorius, the gracilis, the semitendinosus, and then FOT describes the innervation of those muscles by the femoral nerve the obturator nerve, and the tibial nerve respectively for the sartorius, the gracilis, and the semitendinosus, SGT, FOT. So the medial collateral ligament attaches down here immediately underneath the pes anserinus, which is right here. So there's our medial collateral ligament. So we simply want to palpate along the course of the medial collateral ligament, looking for any signs of pain or any complaint of pain by the examinee. We particularly want to dig in over the deep band because that's the band that's closest to the knee joint. And on this examinee, you can see that there's no complaint of pain and there's no reflexive jump sign or withdrawal to indicate that the medial collateral ligament is painful. So that's palpation. We want to continue our exam with range of motion, which is exactly like we demonstrated in the prior video. There are no particular measurements or angles that we need to measure for the medial collateral ligament. So we then proceed to really the only physical examination maneuver that's clinically relevant for the medial collateral ligament, and that involves valgus stress testing, because it's the medial collateral ligament that is our primary restraint against valgus stresses. And with injury to the medial collateral ligament, we have unrestricted valgus angulation at the knee. So what's important with regards to this maneuver is to know that when the knee is in full extension like this, other structures in addition to the medial collateral ligament restrain valgus stresses. When the knee is brought into 30 degrees of flexion, primarily and only is it the medial collateral ligament that is the restraint to valgus stress. So with this testing, we want to bring the knee into 30 degrees of flexion in order to isolate the medial collateral ligament. Now, valgus stress testing can be done on the medial collateral ligament in a variety of different ways, and it seems that every doctor does it a little bit differently. Well, what they all have in common is that the femur is stabilized. Once the femur is stabilized, you then apply a valgus stress to the lower leg in an attempt to open or gap the medial knee joint. So one way that we could do that would be to stabilize the femur here and then simply move the lower leg laterally, looking for any complaint of pain, medial gapping of the knee, any jump sign by the examinee, and we don't see any of those findings. Another way to do it would be to have the examinee scoot over a little bit. Doctor would take the whole leg between his legs for strong stabilization, bring the knee into 30 degrees of flexion, and then simply apply a medial or valgus stress with the hands, assessing for play and laxity of the joint. And this joint is a stable joint and there's no medial gapping, so we conclude that the medial collateral ligament is intact. And then, like the assessment for patellar instability, our normal routine view x-rays for the medial collateral ligament include the AP knee, the lateral knee, the sunrise projection, also sometimes called the merchant view, and then also the intercondylar tunnel view. Now, of interesting note is that on the AP projection of the knee, with chronic injury to the medial collateral ligament, we may see a pathognomonic finding known as the Pellegrini Stieta lesion, which is a calcification generally at the origin, the injured origin of the medial collateral ligament. And actually, the Pellegrini Stieta lesion is something that you could actually even palpate for with your palpation exam. So if indeed there was a Pellegrini striatal lesion, you might anticipate there to be soreness up at the superior origin of the medial collateral ligament or anywhere along the course, and that tenderness to palpation would be accompanied by a feeling of a space-occupying mass underneath the tissue adjacent to the bone. So include the assessment for the Pellegrini striatal lesion in your palpation exam, and then also check for it on the knee x-rays. So that's the physical exam procedure for assessment of laxity of the medial collateral ligament. This is Dr. Perry Carpenter. I look forward to being with you on future videos, and I'm wishing you best of success.